neurology, pathology, ischemic brain disease, strokes, and cerebral edema. All right, so for this next page, it's going to be relatively very high yield for you to understand this whole entire page because they like you to know the disease process and the timeline that occurs after an ischemic event. It's their favorite thing, okay? So once again, let's talk about the ischemic brain disease or stroke. So this is irreversible neuronal damage or injury, okay? And that usually will happen after 5 minutes of hypoxia, okay? So it's very, very quick irreversible damage, okay? Now, if you somehow are able to reverse the damage within 5 minutes, then it can be reversible, but it's usually irreversible. So we have irreversible loss of neuronal function after 5 minutes, okay? Now, they like to ask you this all the time. What is the most vulnerable area in the brain to ischemia? Okay, so which one is first damaged when we have an ischemic event? All right, and it's going to be one, hippocampus. The hippocampus is always hit first, damaged first, okay? And the way that you can remember this, although this might not be like correct actually when talking about pathology, but this is just how I always remembered it. Whenever someone gets like knocked out or they pass out or something happens, they wake up and they're like, oh, where am I? Okay, so that tells me that, oh, the hippocampus is always out first, okay, because they always have their memory out. So the hippocampus is always first damaged in ischemia, okay, or in ischemic brain diseases. All right, and then you have the neocortex, then the cerebellum, and then the watershed areas. But the most important thing to remember is that the hippocampus is most commonly first damaged in ischemia. Okay, now for imaging, they like to say that CT detects the ischemic changes in 6 to 24 hours, but an MRI can detect the ischemia within minutes, 3 minutes to 30 minutes. Okay, but that's not something that they would really test you on when it comes to ischemic brain injury. I just thought it was worth bringing up. Now, next is the timeline, okay? So what happens right at the ischemic event and what happens within the following weeks, okay? They love to question you on the histological features of what happens. So let's start off with the initial 12 to 24 hour period. Within the 12 to 24 hour period, you're going to get red neurons that are formed. Okay, and what does that mean? They have these eosinophilic cytoplasms and nuclear like frogs, okay, that are formed. If you see ever red neurons, eosinophilic cytoplasms, they're trying to hint you towards 12 to 24 hour damage, okay? What they might ask you on the exam is that a patient would have like an ischemic, like they could have like a stroke or ischemic event, okay? And they'll ask you, okay, within these 12 to 24 hours, what are you expected to see? Your answer is going to be red neurons that have eosinophilic cytoplasms, okay? So eosinophilic cytoplasms and nuclear fragments, okay? Frags, okay? That's like the key thing. When they say pycnotic nuclei, they just mean that the nucleus has kind of fragmented. So that's your 12 to 24 hour period. Next, you have 24 to 72 hours. That's 1 day to 3 days, okay? What you're going to be seeing, main thing, is neutrophils, okay? Because remember, neutrophils are always the first responders in majority of cases. When there's damage, when there's any type of invader or foreign material, neutrophils are there to clean it up in the beginning, okay? So that's going to happen within day 1 to day 3. Very similar to our cardiac ischemic events, right? 3 to 5 days, you have the macrophages of the CNS come clean it up. And what are the macrophages of the CNS? We already discussed. Exactly. They're the microglia, okay? So that's going to happen next in the 3 to 5 days. And then 1 to 2 weeks following, you have reactive gliosis, okay? And that's done by astrocytes. They want you to know that astrocytes are going to take the lead 1 to 2 weeks after an ischemic event, okay? And then lastly, you'll have the glial scar formation after 2 weeks of formation. Okay, so keep that all in mind, what certain cell types are going to be present, what it looks like from 12 to 24 hours with the red neurons, with the eosinophilic cytoplasms and nuclear fragments. And then 1 to 3 days is going to be neutrophils, 3 to 5 days is the microglia, 1 to 2 weeks is going to be astrocytes with reactive gliosis, and then finally the 2 weeks or greater is going to be the glial scar. This is very, very high yield. They love to question you on it. And the one thing to remember too is that the first area affected by ischemia is going to be the hippocampus, okay? Now, next is an ischemic stroke. So what happens during an ischemic stroke? Well, we have ischemia, which leads to an infarct in a region of the brain. And then we know that brain is one of the organs, or honestly, like the main organ that undergoes liquefactive necrosis after infarction, okay? So that's very, very important. And the reason behind that is because you have lysosomal enzymes degrading the brain, Okay, so that's what causes the liquefactive necrosis in any type of brain injury. All right. Now, there's 3 types of things that can cause an ischemic stroke. Very easy and very straightforward. Think about it this way. If there's a blood clot in the brain, okay, that's thrombotic. Okay, so a clot randomly forms, okay, over a ruptured atherosclerotic plaque. So think about it this way. In the heart, we have the same issue. There's atherosclerosis in all vessels throughout the body. It's easier to imagine it in the heart, right? Because that's what we talk about. But you can also have atherosclerosis affecting the brain vessels. And if that plaque gets ruptured, then you're going to have a clot forming right at that plaque rupture site. And that can lead to ischemia downstream. Okay, so that's the first episode. The second episode could be an embolic event. Okay, one of the main things that we're worried about, think about AFib, atrial fibrillation, right? You have a clot forming in the left atrium, and then right when you shock them back into normal rhythm, that clot can be shot from the left atrium into the brain, okay? And that can be an embolic event, and that embolus can get lodged in a distal artery of the brain, leading to ischemia downstream, okay? Very easy. It doesn't have to be from the heart. That was just one example of AFib, but it could be from multiple areas, okay? Next and lastly is hypoxic events, right? So we already talked about thrombotic or embolic events that can lead to ischemic stroke, but the last one would be a hypoxic event. So if you're continuously hypoperfused or you have hypoxemia, you're not going to have enough brain or blood flow to the brain. And so that can lead to an ischemic stroke just because there's not enough blood flow getting to the brain, okay? Now, hypoxic events, usually, once again, it's going to tend to affect the watershed areas, and then the hippocampus, once again, is mainly first damage and ischemia. So how do you treat it? Well, we can't go into the brain and place like a stent, right? So what we have to do is we have to give the patient TPA if it's within 3 to 4.5 hours, okay? But you have to make sure that it's an ischemic stroke, not a hemorrhagic stroke, because the risk of hemorrhage when you give TPA increases like tons. So you have to make sure that it's an ischemic stroke and not a bleed. Because if you give them TPA during a bleed, they're going to completely bleed out. Okay, so in ischemic stroke, within 3 to 4.5 hours, you could give TPA. But if that's not possible and there's a large artery occlusion, you have to go in and do a thrombectomy. Okay, those are the 2 treatments that are kind of the optimum. All right. Now, lastly is the transient ischemic attack. Okay, this is known as TIA. So what TIAs are essentially brief ischemic episodes that are reversible. Because remember, irreversible damage needs 5 minutes. But transient ischemic attacks, what happens is that you have ischemia that's less than 5 minutes. You have hypoxia that lasts less than 5 minutes. So you actually have reversible neuronal injury. And they're brief, okay? So very, very important. But they lead to focal neurological deficits, okay? So what does that mean? Well, it's usually going to look like a patient that transiently loses their vision, okay? They have a loss of vision for a little bit, and then it comes back. Or they have a loss of vision in one eye for a little bit, and then it comes back, okay? So this is not a stroke, right? It's not ischemic brain damage. It's just a transient ischemic attack, okay? So it's going to last usually less than 15 minutes, okay? Majority of the symptoms resolve in less than 15 minutes, okay? Now, it's going to present with the transient vision loss because you can have retinal artery emboli from the carotid artery disease that usually leads to transient ischemic attacks. So what they love to ask about is a patient that presents with amorphous fugax, which is essentially the transient loss of vision in one eye that lasts less than 15 minutes. And they're going to say, well, why did that occur? And usually most of the time these patients have coexisting or associated carotid artery disease. Okay, so they have a lot of atherosclerosis in the carotid arteries, and one of small plaque dislodged and went into the renal or retinal artery, all right, leading to the transient loss in vision, all right? And so you treat patients with TIAs, not with TPA, right? Because it's not a thrombotic event, it's not an ischemic stroke. You're going to treat them with statins because statins are going to help stabilize the atherosclerotic plaque and make sure that there's no more plaque that builds up after that. Okay, so you treat patients with TIA with statins, okay? Lastly is cerebral edema, okay? So cerebral edema is just fluid accumulation in the brain, okay? And it's leading to increased intracranial pressure. There's 2 things that cause cerebral edema. The first is going to be cytotoxic edema, okay? So that means that when majority of the cells in the brain start to swell, okay, because of damage. The reason behind this, they want you to know, is due to the fact that there's intracellular fluid accumulation. So all the cells start to accumulate fluid because of the sodium potassium ATPase pump starts to dysfunction. Okay, so when you no longer have sodium potassium ATPase working, you have sodium starts to build up in the intracellular space, which attracts water, and water starts to fill up the cells. Okay, and that causes cerebral edema. They want you to know that sodium potassium ATPase pump is at the center of the issue for cerebral edema when it comes to cytotoxic edema. There's also vasogenic edema, which just leads to extracellular fluid accumulation. Okay, now this can be treated, once again, with hyperventilating the patient, right? Because a drop in PCO2 due to hyperventilation can cause vasoconstriction, and that would lead to an overall increase in cerebral vascular resistance. And so you would have an overall decrease in the cerebral blood flow, leading to, lastly, an overall decrease in intracranial pressure, which is the final goal. Okay? So very, very important to understand that. Now, a pathology that's associated with cerebral edema that they want you to know is Ray's syndrome. So patients that are young kids that you give them aspirin to, okay, because you can't give aspirin to a young kid, right? Because you get hepatic encephalopathy. Well, if you give a patient that has a virus that's a young kid aspirin, they will end up with Ray's syndrome. They'll have an array of hepatic issues, which we'll talk about in the GI symptoms, but they also get encephalopathy. And that encephalopathy is due to the fact that you have astrocyte swelling, secondary to cerebral edema. Okay, so that's the kind of high yield association with this pathology. All right, so for cerebral edema, what I would want you to know is the cytotoxic edema is due to sodium potassium ATPase dysfunction, leading to increased sodium intracellularly. And then for the vasogenic edema, it's going to be due to the fact that you have extracellular fluid accumulation, and you could hyperventilate the patients and overall decrease the intracranial pressure. That's all. If you have any questions, I know this page kind of was a lot, but please reach out.